The first special test within the cervical radiculopathy clinical prediction rule is the upper limb tension test A, sometimes called upper limb tension test 1. And it's the ULTT with the median nerve bias. So sometimes it's just called the median nerve tension test. The patient's going to be in supine, as you see right here, and you need to be positioned on the test side. So I'm going to be testing her right upper extremity, so therefore I need to be on that side. The first thing the PT is going to do is they're going to firmly depress and hold the patient's scapula on the test side. So one common mistake is not depressing or stabilizing the scapula enough. Just because she's laying on the scapula and it's sandwiched between her body weight and the table doesn't mean that the scapula is fixed. It will still move when we start moving the arm, especially if there's tightness. So you need to really get in there with your forearm and really hold that scapula down, as you see right there. And you need to maintain this position of that arm throughout the duration of the test. Now, I'm then going to passively move her test side upper extremity right here, the right side, into the following positions. So we already have scapular depression maintained. So these other positions right here, depending on the source, you might see them listed in a different order. Each of these movements is going to slowly build up more and more tension on that median nerve, so technically the order of these movements does not matter. This is the order I'm going to choose to show you them. The first thing I'm going to do is put her wrist and fingers into extension, particularly the first, second, and third digits. Because remember, the median nerve goes to those 3 digits specifically. You can certainly get the 4th and 5th digits, but you need to make sure for the median nerve you get the 1st, 2nd, and 3rd. Once I have those digits in extension, I'm then going to supinate her forearm. What that means is that the palmar or anterior aspect of her forearm should face towards her head, or her fingers should point outwards. So that's the forearm supination. Then I'm going to induce a little bit of shoulder external rotation. There's my shoulder external rotation. Now you'll notice at this point that my right thigh is pressed against her upper arm right here. I'm going to use that to my advantage because I'm going to need to now add shoulder abduction. So I can basically just inch myself forward and use my thigh to push her arm into more shoulder abduction. That's what I'm going to do right now. So I'm just going to kind of inch forward and get a little bit more of that shoulder abduction right there. Okay? It doesn't need to be crazy up towards 180. This is probably sufficient right here for most people that are going to have tension in the nerve. And the final thing I'm going to do here in this sequence is I'm going to add elbow extension while maintaining these other things like wrist digital extension and forearm supination. Okay? And right here, or at any point before this, she may feel that nerve tension, and she's going to tell me, of course. Now, what constitutes a positive test depends on what you're looking for. If you're simply looking to see if they've got adverse neurodynamics or nerve tension, which might be common in people following a traumatic brain injury, maybe a motor vehicle accident or a fall, then all you're looking for is an increase in familiar radicular or nerve type of symptoms in the ipsilateral shoulder or upper extremity, meaning on this test side. And if they have any of those things, well then that certainly constitutes adverse neurodynamics, and you should probably give them a median nerve glide as the treatment. But if your goal is to rule up a cervical radiculopathy because you're using this clinical prediction rule, you need to take this one step further. So once they've achieved sufficient neural tension with this progression that I've just shown you, you need to ask them to perform cervical side bending away from their test side, meaning contralateral cervical side bending. So because her test side is the right side, she needs to side bend her neck to the left, which she's going to do right now. Okay? Sometimes a patient will get a little bit of rotation in there. That's okay, as long as there's some cervical side bending. So when the patient performs contralateral cervical side bending, or side bending the neck away from the test side, and their symptoms increase, that constitutes a positive test for a cervical radiculopathy, because when they side bend their neck away from the test side, they're putting further stretch on the median nerve, or further tension, by virtue of those brachial plexus nerve roots, and they're bending those away from the test side. Conversely, if she then brings her neck back and side bends toward the test side, so ipsilateral cervical side bending like you see there, that should reduce those symptoms. So if you're considering a cervical radiculopathy, you first build up the nerve tension with this progression, and then contralateral cervical side bending, so away from the test side, should increase symptoms. And ipsilateral cervical side bending, so bending toward the test side, should reduce symptoms. Let's take a look at this one more time. So first, firmly depress the scapula and maintain this position. Then we go through the following progression of movements. Wrist and digital extension, in particular targeting digits 1, 2, and 3. Forearm supination. Shoulder external rotation. Then inch my thigh forward to induce more shoulder abduction, and then elbow extension. And then theoretically right about there, she has familiar symptoms in that upper extremity. If it's a cervical radiculopathy, side bending away should increase symptoms, and side bending toward the test side, ipsilaterally, cervical side bending should reduce symptoms. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.